Okay, well, thanks so much, Amy. A lot to take in, but great information. I'll also ask Yelak to come up and join us on the stage here for a little Q&A. Unfortunately, Amy has to leave a little bit early today for a funeral, and we're sorry to hear that, Amy, but we just appreciate you spending the time that you have with us today. So we're going to do a Q&A for the next 5 to 10 minutes or so, and then we'll have just one short further lecture before we take a break. So Haley and Annabelle are here in the crowd with mics. If there are questions here, I understand a question has already come in from Grace Baptist. Do you want to start with that one, Haley?
Yeah.
Oh, yeah, it's working. It's working.
It definitely works. Okay, so we can go ahead and start with a question from Grace Baptist. Is there a correlation between myeloma and diabetes?
Yeah, what a fantastic question, actually. That's something I got to make a brief mention of a little bit later in the next talk, Race Matters in Myeloma. The short version is, yes, there is a link. I would sort of put it in two ways. In number one, even when Amy listed what we think of as associations, not necessarily causes, but where we see things associated, we know that unfortunately obesity is connected to almost all cancers, actually, and myeloma is one of them. And it's not fully appreciated, understood, I think in kind of simple terms. Unfortunately, in obesity, multiple organ systems in our bodies can be a little bit compromised. They don't just function in quite the optimal way, and then that adversely affects the immune system. And so when the immune system is affected that way, there's an opportunity to develop something like myeloma. And the second, if you will, correlation between the two is a little bit different. It's not so much cause and effect as much as sometimes the presence of diabetes disallows us to see the diagnosis of myeloma because a lot of the symptoms overlap together. And we've had a lot of our African American patients and our Hispanic patients, for example, where in those two populations we know that diabetes is more common, who say by the time they got diagnosed with myeloma, you know, I had these symptoms for 6 months. I had these things going on for 6 months. And the docs kept saying to me, oh, that's just your diabetes. Oh, that anemia? Oh, that's just your diabetes. The protein in your urine? That's just your diabetes. Oh, your kidneys aren't working very well? That's just your diabetes. Oh, you're having a little bit of pain? That's just your diabetes. And diabetes can cause all those things, but they sometimes masks what's actually happening with myeloma. So that's one of the reasons why, as I'll share with you after the break, one of the things we're doing in the Empower program is to try and educate primary care physicians to discriminate diabetes from myeloma so that they don't get clouded, so that we don't delay the diagnosis of myeloma. Great question. I think there's a question up here at the front.
I just wanted to add one thing.
Amy, while we come up here.
It's not uncommon for a patient with myeloma to develop diabetes. We tend to use steroids accompanying every single regimen, and steroids really raise your blood sugar level. So some patients who start off pre-diabetic can sometimes be pushed straight into diabetes from the treatments that we utilize. So that is not an uncommon phenomenon we see, and something we're trying to do better. You know, there's recent literature showing that tapering down steroids can really be beneficial and still tackle the myeloma in an efficient way. So that's one thing that we see from time to time as well.
Thanks so much, Amy. I can't believe I didn't say that, because I'm the one leading the charge on what I've called the new hashtag Down with Dex. So we've been, in fact, I went with our nurse practitioner this week because we're writing an article for JADPro, one of our journals, on this whole notion of what we do in our clinic to turn down the dosing of dexamethasone very soon after we start it, because we've been using too much steroids in myeloma for too long. But I think there may be there's a question back there, and then we'll come to the front. Okay, I'll follow you, H-Dub. I just do whatever Haley tells me to do. All right.
Thank you. Quick question. For those patients who are diagnosed with MGUS, do they have the same kind of extreme fatigue or kidney repercussions or pain in the bones that otherwise with a full diagnosis you might have or experience? And the second portion of that question is, many, many years ago, MDS was considered a precursor to leukemia, but now is considered a cancer. Now, MGUS, I always imagined, was a precursor to multiple myeloma diagnosis, but is it now considered a cancer?
So fantastic question, and I'll be brief in my answer for time's sake, but the short version is someone with MGUS should not be experiencing those symptoms, because by definition, MGUS is you have a small presence of that abnormal protein in the blood, but not enough to cause the kidney damage, the bone pain, the anemia. If those things are happening, then someone truly has active myeloma. Your second question is very insightful about what you called MDS, or for those who aren't familiar, something called myelodysplastic syndrome, is kind of like a pre-leukemia state. I would look at that a little bit differently. So we don't really think of MGUS as being a cancer per se. It is a condition. And it does, when I mentioned earlier that we're looking at screening people and so on, we have to be careful. When someone is diagnosed, for example, even with MGUS, even though it means that they don't have a cancer and they likely will never have it, because most people with MGUS never develop myeloma, it has implications. It can affect the cost of you getting life insurance and health insurance and things like that. So we have to be careful. But we are working very hard to understand that transition from MGUS to myeloma, and there is an intermediate phase called smoldering myeloma, which is maybe a little bit more like MDS, but even then, by definition, smoldering myeloma should not be symptomatic. People should not have kidney damage, should not have anemia. So in that way, really MDS is more like true leukemia. It's just a version, a milder version, if you will, of leukemia. And so in myeloma, we don't really have that. We really have you either active myeloma need treatment or something before it that we just monitor, generally speaking.
Dr. Joe, what's MGUS?
Oh, please.
What is MGUS?
Oh, MGUS, as I had in that earlier slide, or monoclonal gammopathy of undetermined significance. That's a phrase that was coined by one of the grandfathers of myeloma, Dr. Bob Kyle from Mayo Clinic, who I used to have the privilege of working with and still do. He's still on our board for the IMF. And it just means that that little abnormal protein I talked about earlier is present in the blood, but at such a low level, it's not hurting anything. I tell patients it's like finding a little dust in the corner. It's there, but you don't need to clean it out because it's so small. But we do have to watch it because it can potentially grow. About 1% of people with MGUS in any given year, it will grow into myeloma.
Before I ask my question, I just want to thank you. I've had it for maybe 5 years now, and I have a wonderful doctor, but I learned so much more here today than I've done in the last 5 years. So before I even ask my question, I just wanted to thank
And I know you came super early this morning, so I hope we've rewarded you.
I had no
for getting-
choice. It was the only way I could get here, but that's
We're thankful. We're thankful you're here.
Are there different types of myeloma?
Yes. So the question was, are there different types of myeloma? And, like with almost any other cancer, I mean, we could say the same of colon cancer, of breast cancer, and so on. We call it multiple myeloma because it's really spread out all over the body in many respects. But even within that umbrella of myeloma, yes, there are different types. Sometimes we divide them up by the kind of the antibody. Like when we make antibodies in the body, we have different types. We call IgG and IgA and IgM. They're different types that way. More importantly, we tend to divide myeloma into what we call standard risk and high risk. And it just means a little bit about how fast the disease can grow, what I call the horsepower of the disease. But more often than not, we treat pretty much all myeloma in the same way. But without getting into too many details, yes, there are sort of subcategories. And even beyond that, there are other diseases that are sort of cousins to myeloma, things that aren't quite myeloma, but are similar to myeloma. We have things called amyloid and light chain deposition disease and other things like that. I think we have time for a couple more questions, please.
Can long-term use of medications for autoimmune diseases, could it cause myeloma?
That's a great question.
Methotrexate, Orencia.
So the question is, can immune disorders or long-term medications cause myeloma? It's a little bit like the question I was asked earlier about obesity. We're still trying to understand it. It's not a very simple cause and effect phenomenon where we can just say, oh yes, this drug. I mean, there are certain drugs and certain exposures we know are very much connected to lymphomas, and lymphomas tend to be a bit more common than myelomas. But yes, we do believe that there are certain exposures that may put people at slightly increased risk. So the way to think about it is, maybe it's not just that one drug that did it all, but if we do that in conjunction with someone whose own inherent genetics puts them at risk of it, and what other things that we still haven't figured out may cause myeloma, when those things sort of happen, it's an unfortunate perfect storm will eventually triggers the disease. Got a question here?
So we have room for one more, and then I'm going to ask a question from Grace Baptist, and that will
Okay,
be...
so we'll take the last two questions here. Great.
Hi, good morning. Thank you for having me here. I wish to thank you very much, and you professionals. Being here is a special day for all of us to come to the special events. My question is, what do you think about holistic medicine? Can that play a big important part? Because I feel like that could help a lot in your life if you study like holistic medicine, like acupuncture and so on. So what do you think about it?
Yeah, no, I try to be, I think we all try to be very progressive in our thinking. You know, as I said earlier, it wasn't just a tagline, I don't treat myeloma, I treat people. And we have to look at the whole of the person. And so we are, as Amy was indicating, and even as Yelak was indicating in his life experience, that it's not just about the drug for myeloma. It's not just about, you know, these great things we're going to hear from Dr. Osmani in a few minutes about, you know, CAR T-cell therapy and these exciting things and bispecifics that we're using. The whole of the person has to be looked at. And so part of that support is looking at often what have historically been thought of as alternatives that may help that person in different ways. And I've had many of my patients I know benefit from acupuncture, benefit from other things. We always have to be cautious that I know sometimes people can maybe swing the pendulum a little bit too far and they want to take all these extra supplements and so on. I always tell patients, look, if something's strong enough to help you, it's strong enough to hurt you too. So it's always important to have that conversation with your provider to understand, because sometimes people hear, oh, this is a natural product, it must be good. I live in Arizona, I tell people snake venom is natural, right? So we have to be careful, right? And so there's always a balance in that, but I think modern day medicine is starting to appreciate that whether it is, you know, our sleep hygiene, the impact of dexamethasone on our bodies, these other things that we don't think of immediately as treatment really help the patient in and of themselves. Even we've learned communicating, as Amy shared with us, we've learned in oncology, if you have a good communication system between you and your provider, it actually affects your prognosis. Cancer patients who develop a good relationship with their healthcare team live longer. So all of those things are very important. All right, Haley, we'll take the last question.
Can I just add one more thing?
Oh, please, Amy. Yeah, please.
Yeah, so I think, you know, traditionally they always thought that providers were against holistic alternative medicines, but it's just because we're so evidence-based, and we've done a lot of studies, and so things like acupuncture, things like massage are very beneficial for cancer patients. In fact, at MSK, we have a whole complementary medicine division. We actually have an acupuncturist on site. So we understand what actually does benefit patients, particularly for management of side effects. So don't ever hesitate to bring this up, because there are things that really do complement what we do.
Holistic, alternative, complementary. I would prefer holistic and complementary, not alternative, right?
Yep, because it's all part of the same package, absolutely. Hey, Haley, there's one more question from Grace Baptist.
Yes, so this is coming from Grace Baptist. I have been told my stem cells should be harvested. Can you explain this procedure?
Okay, great question. And I know that Dr. Usmani will talk a little bit after the break about how we treat myeloma. But very briefly, the concept here is, remember how I said myeloma is a cancer of that bone marrow, the factory of our blood. We have other cells in our factory that are called stem cells. Think of them like seeds that can grow more cells in the future. And one of the ways we treat myeloma is through what's called a stem cell transplant or a bone marrow transplant, where actually we extract from patients before some of these stem cells that can basically grow a new bone marrow. Then we give them a big dose of chemotherapy to try and get rid of the cancer that's in their bone marrow, and then give them back the stem cells to grow a new one. It's kind of like saying, you know, there's some weeds here on my lawn. The only way I can get rid of it is to burn the lawn. But before I burn the lawn, I want to make sure I have seeds to grow a new one. So we keep seeds in the garage or wherever we do, and then we can seed a new lawn afterwards. And so collecting those seeds or those stem cells is something we often do when early on in someone's diagnosis after we've given them a little bit of treatment, because some patients may be eligible for this procedure or this process called the stem cell transplant. Whether we'll be doing those in the future, we're still to decide, but right now we still do that. So that's something that's really important to discuss with their provider to see, are they eligible for it? Is this something that we should potentially do?
Even 28 years ago, I collected my stem cells and stored them, did not use them immediately, And I found out several years ago during the merger and acquisition of the hospital system decided to discard them. So I went ahead and recollected. So the process of collection is a little bit inconvenient, for a lack of a better word. You get that catheter inserted and you are attached to a machine for 5-6 hours, maybe for 2 or 3 days. But at the end of that, you have stem cells collected. Whether you get them infused after that chemo Dr. Joe mentioned is a conversation between you and your physician. But I think studies have shown that whether you do it immediately after your initial treatment or at your first relapse, there is a conversation to be had.
Excellent. And I'm glad you jumped in because I knew you were going to comment about this long and not yet having a transplant. So, well, we could answer questions all day, and we do have time both at the break and later for more questions. So thank you very much to our panelists. Thank you again for being here today, Amy.
Of course, thank you.